Welcome to The Explainer. Today, we're digging into a trial that could really change the game for small cell lung cancer. It's the DeLLphi 304 trial, hot off the press from the New England Journal of Medicine. And yeah, this one's a big deal. All right, so let's just get right to the heart of the problem here. You know this as well as I do. For decades, second-line treatment for small cell lung cancer, well, it's been a tough road. I mean, once that first-line platinum therapy fails, what are we left with? Topotecan? Maybe, and the benefit is, let's be honest, pretty modest. We're talking a median overall survival of maybe 7 to 9 months, and you're dealing with some really significant hematologic toxicities. That's the reality we face every day in the clinic. And it's exactly that challenging landscape that sets the stage for the DeLLphi 304 trial. The big question it's trying to answer is, can a new immunotherapy finally break this cycle and give us a real, new standard of care for these patients?
So the drug we're looking at is called Tarlatamab. Now this is a bispecific T-cell engager. The easiest way to picture it is as a sort of molecular matchmaker or a bridge. One arm of this molecule grabs onto something called DLL3, which is a protein that's on the surface of something like 90% of small cell lung cancers. The other arm grabs onto CD3 on the patient's own T-cells. So it literally pulls the T-cell right up to the cancer cell, forcing it to engage and, well, kill it.
So with that mechanism in mind, the question for this Phase 3 trial was super straightforward. It's a direct head-to-head comparison. Can Tarlatamab actually do better than our current standard of care chemotherapy for these patients with relapsed small cell lung cancer? It's a simple question, but a huge one.
Okay, so how exactly did they set this up to get a clear answer? Let's take a look at the trial design.
All right, so what we've got here is a big, multinational, open-label, randomized control trial. They took over 500 patients with small cell that had progressed after their first platinum-based chemo and randomized them 1-to-1. So half the group got IV Tarlatamab every 2 weeks. The other half got the investigator's choice of standard chemo. You know, the usual suspects: topotecan, lorlatinib, or Amrubicin if they were in Japan. And the primary endpoint, the one we all care about most, overall survival.
Now this is where it gets really interesting for me, and I think for you too. Look at who was actually in this trial. The groups were nicely balanced, sure, but look at these numbers. Median age in the mid-60s, a whopping 44% with brain mets, and another 44% with platinum-resistant disease. We're talking progression within 90 days of first-line chemo. Let's be clear, these are not the easy patients. This is a tough, real-world population. This is exactly who we see walking into our clinics.
Okay, so given that they studied a pretty tough patient population, how did Tarlatamab actually do? Let's jump straight into the efficacy results. Well, the results were pretty definitive. The study smashed its primary endpoint for overall survival. The hazard ratio was 0.60. Just think about that for a second. That's a 40% reduction in the risk of death for the patients who got Tarlatamab compared to standard chemo. That's huge.
And to put that into real-world numbers, it translates to a median overall survival benefit of 5.3 months. 5.3 months longer. In a disease where for years we've been fighting for gains measured in weeks, this is just a massive leap forward.
Let's break that down a bit more. The median overall survival was 13.6 months for Tarlatamab versus only 8.3 months for chemo. And if you look at the 1-year mark, you can see it really clearly. 53% of the Tarlatamab patients were still alive, compared to just 37% of those on chemo. The Kaplan-Meier curves, they separate early, and they just stay separated. It's a really clear signal. And you know, this wasn't just about overall survival either. The positive story held up across all the key secondary endpoints. We saw better progression-free survival, and look at the objective response rate. It was almost double what you see with chemo. We're talking 35% versus 20%. Really consistent data.
But for me, this next part is what really hits home. This wasn't just about making the scans look better or extending survival curves on a graph. The patient-reported outcomes showed that people on Tarlatamab actually felt better. They had real meaningful improvements in those awful symptoms that crush quality of life, like shortness of breath and cough. So they weren't just living longer, their quality of life was better too. That's a huge win.
Okay, so it's clearly more effective. But what's the trade-off?
Let's dig into the safety and tolerability, because that's always the other side of the coin.
So, is it more effective but also more toxic? Well, the data says no, actually. The rate of severe, grade 3 or higher adverse events was way lower with Tarlatamab. We're looking at 54% versus a staggering 80% with chemotherapy. And the type of toxicity is completely different. With chemo, you get what you expect: bone marrow suppression, cytopenias. With Tarlatamab, you're dealing with the known class effects of a T-cell engager.
All right, so let's talk about the main one, cytokine release syndrome, or CRS. This is the widespread inflammatory response you expect when you activate T cells. And yes, it happened in about half the patients. But, and this is the critical point, it was almost all low grade. We're talking 98% of cases being just grade 1 or 2. It was predictable too, usually popping up after the first couple of doses. In fact, it was so manageable that they ended up amending the protocol to allow for outpatient monitoring. That tells you a lot.
And what about neurotoxicity? The other big one we worry about with these agents is ICANS. The good news is, it was pretty infrequent here, showing up in only about 6% of patients. And again, when it did happen, it was generally low-grade and manageable. Now, we do have to acknowledge there was one tragic grade 5 event, which is always important to keep in mind. Okay, so let's pull all of this together. What's the clinical bottom line? What does this mean for you in your practice on Monday morning? When you put it all together, the takeaways are pretty clear. First, for our patients with relapsed small cell lung cancer, we have a therapy that gives a significant, clinically meaningful survival benefit. We're talking over 5 months. Second, the safety profile is actually better than chemo, with fewer severe AEs and none of that hematologic toxicity we're so used to, which leads to the third and most important point. These results really do establish Tarlatamab as the new standard of care for second-line treatment of small cell lung cancer.
Look, this is genuinely a landmark trial. It completely reshapes the second-line landscape for small cell lung cancer, but it also makes you immediately ask the next question, right? If it's this good in the relapse setting, what about moving it up? What about earlier lines of treatment? Of course, those trials are already up and running, which could mean an even bigger shakeup is coming for how we manage this really aggressive disease.